Hello students, today we are going to continue the part 2 of the lecture on orthopedic designs. We are going to mainly focus on hip and knee and just a very brief overview of the two joint replacements. Hip has been really successful as the forgotten joint right now. The hip arthroplasty has been acknowledged as the most reliable procedure to relieve hip pain and restore function. Very reproducible results, very good long-term results, as this paper back in 2007 is claiming the operation of the century being total hip replacement. On the knee side, also largely very successful, but not as successful as hips. We still are seeing abnormal kinematics in some of the cases. We have up to 20% of the patients not satisfied with their knee replacement surgery. And for the top reasons for revision, we have been seeing from the entire history, instability and loosening, we still have not entirely resolved the issue. And you can clearly compare between hip patients and knee patients. Knee patients are not entirely forgotten their knee, so it's not a forgotten joint as hip. Well, let's talk about knee designs first. And there are a couple ways to look at knee designs or categorize them to frame our lecture. So first of all, I want to talk about knee designs for the continuum of care. That means as the patient's disease progress, we have different knee designs to address that, from the uni-compartmental knee arthroplasty to primary total knee to the revision total knee. So first we talk about the uni designs. As UKA usually is used for single compartmental arthritis, and from the usage standpoint, you probably will see 90% of the cases are on the medial compartment replacement and the other 10% being lateral compartment replacement. It has been actually gaining a lot of increasing popularity in the Western world, especially in the US. There are claims that 40%, 50% of the TKA can actually be UKA, so it's gaining a lot of traction. Speaking of UKA, the surgery itself, probably the most hot topic is about how to properly select the patient. There are a lot of criteria people are debating on. Here I have a little summary here to help you understand some of the areas we know. We have a kind of a consensus on the patient selection, but there are also many areas people are debating on whether to use those as the criteria to select patients. So this is probably the controversy about UKA right now. Speaking of UKA designs, they are anatomic approach design, as we talked in several of our previous lectures, because they aim at preserving cruciate ligaments and soft tissues, and it's really a kind of resurfacing surgery rather than significantly changing the structure, the bony structure. So during the replacement, it's not targeted to manipulate the ligament tension or balance in the knee. The advantage has been shown through a lot of studies over TKA that UKA can produce more normal kinematics, definitely more bone conservating, minimal invasive surgery, and fast recovery, less complications. So outcome-wise, the UKA patients do enjoy a better outcome compared to TKA. From the design standpoint, as we mentioned, it's an anatomic approach. So in general, if we're using fixed design, because the poly insert is locked into the tibial base plate, So the key of the anatomic design approach is to not constrain the motion of the knee by mechanical constraint, but rather letting the soft tissue to drive it. Fixed bearing design usually has curved femoral component on a flat poly insert, such that the femoral component can move freely on the poly, such that the soft tissue can drive it. But as you can see on the upper right figure, if you have a rounded femoral component on a flat surface, you may have this point loading that cause stress concentration and may be a concern about poly wear. But for the current materials we have, the poly materials, we are having a much better material compared to back then to minimize the poly wear. And because it's flat surface, it's fixed bearing, it's very easy to do the surgery compared to a mobile bearing design. So the reproducibility of the surgery is pretty good. And we also have mobile bearing design. And in this case, it trying to address the stress concentration situation in a fixed bearing design, such that in the image at the bottom right, you can see between the femoral component and the tibial insert, they actually have high congruency between them, such that you have large contact area and low stress, so that may minimize the stress concentration. But the poly insert itself is allowed to move freely on the tibial base plate. So this will avoid the conflict with motion caused by the high congruence between femoral component and the poly. But because then we have really a large moving part in the joint replacement, and there may be concern about dislocation of moving parts. So that the knee has to be, with that freedom, it probably would be properly balanced soft tissue-wise, such that with the freedom, it would not go too much freedom that causing problem. And there are clinical data available to support both choices. They all produce pretty good clinical outcomes. However, we have seen historically higher revision rate compared to TKA. At the beginning, it's the design of the UKA, and with the current more sophisticated design and the material properties we have in the insert, it's from the engineering standpoint addressing a lot of earlier issues. The main reason for revision was they are shown to be the disease progress of the other compartment. For example, if you replace the medial compartment and later develop lateral arthritis, and the surgeon may elect to have a total knee to take care of both at the same time. Component loosening still is an issue and pain. So one of the understanding for now, once people review the reason for revision of UKA, and then trying to understand why, is there any other reason why there is a higher revision rate for UKA? People notice that for TKA, if you have unexplained pain, the surgeon really cannot do much about it. It's not worth to go to a revision for a well-fixed TKA, primary TKA, to address pain, and probably it will not resolve the pain by another revision TKA. But for UKA, when patients are complaining about pain, a lot of times surgeon would just elect to go to TKA. So the criteria for revision is much lower for UKA patients compared to TKA patients. That may actually explain a lot of high revision rates of symptom-wise really well-fixed UKA, but went through revision. So that's something to be kept in mind when we look at the revision rate. Now we talk about primary total knee designs. And we have mainstream designs, as most of us know, PS and CR designs. and there are newer designs also available, medial pivot and bicruciate retaining knees. And you can probably use our knowledge regarding functional approach and anatomic approach to understand what was the approach these designs was considering back then during their development process. So talk about PS design. Majorly, if you look at PS, you will notice a box on the femoral component. It's preventing the post engaging with femoral component in extension. And you will notice also a cam and a post. The cam on the femoral connecting posterior femoral condyles and engage the post inflection, usually between 40 to 90 degrees. And the post on the poly side engages with cam during flexion, then it helps to drive the femoral posteriorly relative to the tibia. So that's recreating the femoral rollback as we see in the native knee. So this cam post mechanism is the soul of the PS design. And the modern designs usually can achieve terminal flexion of about 130 degrees. So the PS design has a benefit or advantage. It's really easy to operate on because we're not dealing with ACL and PCL. They are sacrificed from the surgery, and so the results, functional-wise, is more reproducible, easy to achieve. The cons contain it's definitely not very bone conservating because you have to cut off that big box to create the PS, the cam post mechanism. And depending on the surgery, how the surgery is performed, and even for the earlier designs, the cam and post could have a risk of dislocation. And polywear at the post, because post is taking a lot of stress on contact with the cam, so polywear can be a problem. And also when the femur is getting into flexion, the patella gets to be engaged initially with the notch, with the box, the top of the box. And sometimes if the surgery is not properly done well, the patella clunk may happen. And it's also important to be able to balance the flexion extension gap properly. That will partly, if you have a too loose of the flexion gap, that may cause dislocation of the cam post. So that's the PS design. Moving on to CR design, as we can see from the name, is cruciate retaining, so it's retaining native PCL. ACL is always resected. The particular design, once you see from the image, you will notice it does not have a box. It does not certainly have a cam post, and it also has a cutoff for be able to leave the room for PCL. In theory, preserving the PCL will result in preservation of native mechanics, kinematics. So that's the basically where it came from to have this type of design, and it's bone conserving, so no box is needed. The disadvantages include it actually is not as easy as a surgery compared to PS design, because you will have to pay attention to soft tissue balancing of the PCL. Particularly when we have deformity, that's even harder to manage the soft tissue balancing. Historically, we have actually reported abnormal post-op kinematics, such as paradoxical motion and insufficient rollback by the CR design. And it depends how the surgery was performed. Sometimes actually people see PCL got damaged during the process, the surgical process, the bony resection. And because then after surgery, the PCL still plays in the kinematics, so there is still a risk of PCL rupture, especially if the PCL is unwantedly damaged during the surgery. So comparing CR and PS designs, we know CRTKA is more challenging to perform due to you have to balance PCL, you have to preserve PCL. And between the two types, clinical data-wise, there is no clear indication of which one's better. They both are providing good clinical results. Well, speaking of these two main designs, I do have to add this extra slide in regarding the availability of increased congruency poly insert. So once we have, for example, in the CR surgery, insufficient PCL, well, it's probably still can work. The surgeon may opt to, instead of going to a PS, using a UC design that is providing more stability anterior posterior wise, and also it comes with more conformity, so it can minimize the stress. In the PS also, there are designs that can give you constraint regarding rotation in various valgus direction and internal external rotation. So there are designs available if you need additional stability due to soft tissue deficiency. These poly insert will be able to serve you, enable you to still use, stay on the device type you want to use, and then with added stability. The newer designs we are going to talk about, their goal in general is to achieve not only just survivorship and general outcome, clinical outcome, but really for better natural kinematics. What do we know about native knees is that they exhibit medial pivot motion during the range of motion. And then as you can see on the bottom, actually the right image, as the native knee is going into flexion, it actually has a pivoting point on the medial side. So it looks like the femoral tibial contact point slides more on the lateral side AP-wise compared to the medial side. So ideally, we want to recreate that with our TKA such that we can have this normal kinematics. However, if you look at the colorful image at the bottom, these are the images that's showing paradoxical rollback. So the right side is mostly implants would show you it will have a straight rollback, may not be even medial pivoting, but as you flexing from extension to flexion, you can see the contact points on both condyles are rolling back. That will facilitate your flexion and facilitate your range of motion. But on the right side, it has the paradoxical rollback. That means at the beginning of the flexion, if you look at from red to green, so early flexion angles is actually going forward, the contact points, then roll back. So that's abnormal, which we do not see in the native knee. So knowing the limitation of the existing device, sometimes even abnormal rollback, these newer designs are trying to address this by enabling better kinematics. For bicuspid retaining design, BCR design, the concept is to preserve both ACL and PCL, so there's no ligament release of these cuspid ligaments. And the poly insert is intentionally kept to be flat such that the ligament can freely drive the knee motion. So advantages, in theory, if you preserve the ligament and they are functioning really well, then you're going to have more natural functional outcomes. The disadvantages include, well, first of all, the patient selection is very critical because we want to make sure the knee has healthy ligaments, healthy soft tissue to enable the kinematics in the first place. And it's very sensitive to knee deformity as well, so we need to really carefully select the patients. And because now we're balancing, remember when we are talking about CR, it's more difficult to perform than PS surgeries because CR, you have to balance the PCL. Now you have PCL and ACL. So you will have to balance multiple soft tissues at the same time. That makes this surgery even more technically challenging. And all these would affect outcome, performance, and survivorship. Speaking of a medial pivot design, this design, the concept is to, through the poly insert design, to allow more freedom from the AP sliding standpoint on the lateral side of the poly. And then on the medial side, it's more a ball in the socket kind of design, so it's limiting the AP movement. In that fashion, the artificial medial pivoting pattern can be created. So that's supposed to benefit and recreate the medial pivoting pattern throughout the flexion ROM. So we talk about mobile bearing design as well, and in knees, of course, we have multiple mobile bearing designs available in the market. And the idea, as we mentioned a couple of times before, is to have high congruency between the femur and the poly insert, such that to reduce less contact stress, and then allow the poly insert to either rotate for some design, even with AP and ML translation on the base plate, and that will allow soft tissue to drive normal knee motions with that freedom. So the idea is by providing lower wear risk and also better freedom, the knee soft tissue could drive the knee to a more natural kinematics. So we have all these design types available. Which one to use? We would say that for the traditional CR and PS design, they are clinically tested throughout history and being very, very successful and reliable. For the newer designs, not to say they're not good, they're showing a lot of early outcomes that's very positive and sometimes even better than the traditional designs. However, we still have limited clinical data in terms of midterm and long term. So that takes us to research more on these designs. But these could be promising design choices to address patients' needs on their functional restoration. And one thing about the newer design is that to be kept in mind, they are generally more technically challenging to perform. So you may want to really practicing picking up the skill set to do the surgery, and sometimes even rely on advanced surgical technologies such as robots and navigations to help accurate surgery. So for now, CS, PS, and CR designs, they are still the golden standard for reproducible and confident outcomes. Moving on to revision TK, it's a whole lot of art of surgery we can pretty much spend a whole day to talk about. So today is only a high-level summary. The primary TKA top reasons for failure: infection, loosening, and instability. And when they pass on to the revision stage, the revision TKA had to address some of the failure mechanism caused the primary TKA to fail, and also the bones, the knees comes in after removal of the primary device, often with bone loss of varying degrees. On the right side, you can see different types of bone loss. They are actually classification system for bone loss. So the management of bone loss is also very, very critical. And the soft tissue comes in with compromised status as well. So balancing the soft tissue is also difficult or challenging. So in one word, to rebuild the knee, without knowing the native status, dealing with bone loss and compromised soft tissue. That's an art of surgery. So in general, revision TK components, you will see highly constrained polyinsert with tibial femoral articulation being constrained and with that high congruency, because you need that added stability of the knee. And bone void management and joint reconstruction, they are a focus for the surgery, and basically requires stability assistance through stems. And you often noticed the revision TK portfolio contains a lot of different implant parts, not just a femoral component, tibial component, and patella. It comes with all sorts of stems, sleeves, cones, augments, and wedges. And first of all, highly constrained femoral and tibial component to provide stability, and stems and sleeves for additional stability. And you have cones, sleeves, augments, wedges for managing the bone void. So that's a lot of Lego blocks to use to create the art of the surgery. And of course, to cement or not to cement, in TKA, both cemented and cementless designs are available. And as we mentioned before, they both produce good clinical outcomes. There's no clear preference. Most surgeons still preferred cemented TKA for they feel comfortable for that initial fixation, and do not have to worry about biological ingrowth, and also the patient selection criteria would be much forgiving. However, recently we are still seeing cementless usage is increasing. For the cemented design, you always notice they have a pocket, cemented pocket design on the back side of the tibial base plate. So that is to facilitating fixation or penetration between with the cement. So that's improving fixation strength. Cementing technique is important. And in the recent few years, we actually even noticed that the selection of the cement type also important. There are studies published on if we're using high viscosity cement during the surgery while the cement is setting, we are not supposed to manipulate the knee too much that it may contaminate the cementing surfaces that later leads to less fixation. So when you are dealing with high viscosity cement, make sure you pay attention to not manipulate too much during the curing process. For the cementless standpoint, we have been over the years figured out the optimal design factors, porosity, pore size. We want the biomechanics of the material similar to cancellous bone. We want high friction coefficient for initial fixation, and we know what is the criteria for a good ingrowth from the fixation micromotion standpoint. And also through research, we know that the initial seating of the cementless device on the bone is very, very critical. We want to ensure always a full seating for a better initial fixation and ingrowth. So what about the other joints? Well, we've looked at the hip design. As you may already know, the hip design comes into several components. We need an acetabular component that contains cup and liner, and we have a femoral component that's head, neck, and stem. It may comes in as one piece or modular, and it's really in general a ball and socket design. So theoretically simpler than a knee design. So when we take a closer look at these components, what are the factors we need to pay attention during design? Acetabular standpoint, the modern designs are press fit, and we really need to make sure the locking and press fit of the cup and the insert cup locking, and also the polished matching cup liner surfaces. These are all important to consider. The strong locking will prevent relative motion, and the polished matching cup liner is to minimize wear. On the femoral component standpoint, as we mentioned, we have non-modular design and modular design. When we have the modular design, it's actually more versatile in terms of customize the anatomic restoration. But however, because it's modular, so we need to pay attention to taper junction corrosion. That's still a concern that may cause metallosis as a clinical result. And to talk about bearing surface materials, there are a number of bearing surfaces materials pairs actually. The most popular ones right now are probably metal on poly and ceramic on poly. The other ones have their own pros and cons. For example, if we have a metal on metal, we had some historical failure regarding the metal debris from the wear. So I'm not going to go into much of the material properties for now, but the top two are metal on poly and ceramic on poly. So we've talked about in the design types, fixed and mobile bearing. They are both available with hip design. So one thing you may notice, why so many different stems? Why do we need a lot of combination either in modular design or just a single piece, different types, shapes, size of hip stems? So first of all, it's important to have different lengths and width for fixation. And also by, for example, the modular design to enable you to restore the center of rotation. Because if you look at the geometry of the stem, you notice that it has this three things: vertical offset, horizontal offset, and diversion. And you can see how using different stems combinations can change these offset, these geometry of the hip. That will directly impact your anatomic restoration of the hip joint. So that's why we need a lot of different combinations to address the needs. And what happens at the head and cup? If you look at these head-neck ratio, so that's the ratio of the diameter of your head size compared to the diameter of your neck. So if you have a big head on a small neck, as you can see in the image, you will have more range of motion. And also, if you have big head on a small neck, you will have more distance to travel before dislocation. So ideally, you would actually want a higher head-neck ratio. Bigger head size relative to the neck size will increase ROM, decrease impingement, less risk of dislocation, less wear, and more stable. So that's to be kept in mind. Then move on to total shoulder arthroplasty, just briefly overview. It's still similar to ball and socket design as hip. Modular humor component available, so the humor component can be modular or not. It also comes in with cemented and cementless choices. And one thing, if there's just one thing to know about TSA, is that it has two schools of designs. The first of all is the standard shoulder design, as you see the left image. Typical ball and socket, similar to hip. Also, it has another school, the reverse shoulder design. That's the figure on the right. So you can see the ball and the cup actually flip their location. Well, what's the benefit of this design? It's actually beneficial in the case that a large rotator cuff tear exists, such that if you use this design, it will allow the use of other muscles to drive the shoulder. So it's putting less stress or challenge for these patients. So knowing the benefit of the design, and it may indicate when you see a certain type of patients coming up, reverse shoulder may give more benefit than standard shoulder. Just one thing to keep in mind for TSA. With that, we wrapped up the orthopedic design lecture. Thank you.